Okay, so we have a lot now as we continue to try and grasp what's going on with this virus, numbers coming out from the CDC, as well as trying to figure out everything from antibodies to a vaccine to blood plasma as well. Let's start with the CDC and big numbers coming out from the CDC about actual deaths and impact on the virus to people that have already pre-existing condition. What did you make of the release of the numbers? Significantly lower, of course, than what has been put out and been discussed leading up to that.
It's a very confusing picture at this point, and I think that we know that there is a large number of individuals infected in the United States. If you look at absolute numbers, we're clearly close to or above 6 million infected individual. We're close to 200,000 mortality figures. The whole game of numbers is one where I really can't make heads or tails of. I can tell you that. The question is, of course, is what are these, if the numbers are conservative, meaning that the numbers that we're reading about are conservative, that means that there's more people infected, we're just not testing enough. If the numbers are generous, meaning that they are representing more infections than there actually are, it's kind of hard to put your hat on that kind of stuff. I think that basically this is a pandemic. You could see from other countries the rate of infection. Ours has always been high, and we certainly lead the world in many ways on that side. But even other populous countries such as India and even looking back at China, you could see that this virus spreads pretty quickly and infects a lot of people. So whether we want to say it's not 6 million, it's 5 million, it doesn't matter. It's still a large number of people.
Does that do anything as far as protocol? I mean, what do the numbers do to come out that way, especially something as low as what has been predicted and really discussed as far as a result? Like, what, outside of the political ramifications, which are obvious, from a medical standpoint, does that do anything different in how you treat the virus? Does it do anything different in how you study the virus, or anything from the longs of a vaccine and working on that to just simple protocol?
So let me just back up just a few minutes or a few steps, because I think your question is very sophisticated. You have to think in terms of two ways. One is healthcare, meaning medicine, as you mentioned. Well, the medical care really is a physician, nurse, or any other healthcare professional taking care of a or multiple patients. On the other side is the public health issue. So you're dealing with an epidemic or pandemic, that becomes a public health issue. And both of those are handled very differently. In the public health arena, there are two things. Number one is you want to look at the prevalence and frequency of a disease as it develops, meaning it's usually an infectious disease or something that can contaminate a situation. And that's the public health is trying to put trying to put together the source of where this is coming from, and at the same time trying to mitigate the spread of whatever this condition is. On the other hand is the individual comes into the hospital who's ill and needs care. Those are two very different things in terms of how we approach it. So vaccines become more of a public health issue. All the other therapies that we're dealing with are local, healthcare, like in a hospital or in a medical center. The problem we're running into right now is that both media as well as, I think, the politics around this are confusing the public. And in addition to confusion of the public, I think there's also confusion amongst healthcare providers, because we're reading the same news that you're reading, and we're getting our information from the same sources in many ways that you do, especially in the public health arena. And internally, we're also getting information in terms of what's best to treat patients who come into the institution. So, as I mentioned, those are two different avenues, if you will, and both of them can become very confusing because of the amount of information that we get. Now, I've never seen, there's a lot of I've never seen in my lifetime type of situations right now, but I could tell you that I have never seen the amount of published data in medical literature on as I have with COVID-19. And not all of it is, when I say reputable, it probably is for lack of a better word, not all of it is well vetted. As an example, the NIH has now endorsed the use of a steroid based upon a news release from a group in the UK that are doing very large studies. Now, the news release may reflect what the study is, but as a clinician, I have not seen the study and I can't really weigh benefits versus risk, although the benefits, if they're great, the risk becomes smaller. But we've never seen, or at least in our lifetime, this unprecedented release of data that is incomplete in many ways and has changed the way we treat patients. So confusion is amongst us all.
What do you think is fueling that? Where with Ebola or swine flu or the pandemic 100 years ago, was it simply a matter of it not being as prevalent because we didn't have as much technology? Or like what changes now versus unknowns that we faced before where you didn't see as much stuff out there written or being followed, adhered to by the medical community, either created or followed by the medical community that would be so fragmented?
Good question. So there are two elements to this question in terms of an answer. The first one is that the SARS-CoV-2, which is the virus that we're dealing with, is highly infectious as compared to Ebola, where it's highly infectious and relatively quickly deadly. But because of the public health response to Ebola, it's not spreading as quickly as we've seen in others. We have the same thing with SARS, if you recall, where it really affected the Canadian shores a lot more than us, but somehow it disappeared because the virus did not have longevity for whatever reason. And then there was the H1N1, which again had some level of infectivity, had high morbidity and mortality associated, but nothing has so far compared in many ways to this COVID-19 pandemic or the SARS-CoV-2 that we're seeing. So that's one element, is the infectivity. The other element in terms of the data that we're seeing is we're living in we're not in the industrial revolution. We clearly are in what I'm thinking of the word is,
Technological?
what's that?
Technological?
Not technological, but not electronic, but why am I blocking on the word? But anyway, the transmission, right? Transmission of information in today is so much quicker, and also the amount of noise that's being created by transmission is enormous. And it's very hard to sort through it. Okay, so it is a clearly revolutionary in many ways. So you have, on one hand, you have a highly infected agent, and on the other hand, you have a high soundboard, if you will, in terms of information being transmitted, reliable or not. It's sometimes very hard for us to sort that out. So what I'm thinking is really the digital revolution rather than the industrial revolution, which had its issues too, and they're pretty much parallel to what we're seeing today.
So now, as we head into September, and we know that certain sports like football, for example, is back in some areas, are going to have low capacity of fans. We have indoor dining that's back up, especially in this area. Philadelphia and New Jersey has opened that up as well. How much of this, and again, it's not to apply any type of morality to it, but how much of this is a result of trying to push back against the shutting down of an economy versus we've actually made enough medical strides to justify these decisions to the point in which there isn't any wiggle room to say, look, we get it, you want to reopen for economic reasons, but there's still medical concerns as far as limiting indoor dining or limiting a stadium to 20,000 fans.
So we're living in a country that allows people to make choices. It doesn't necessarily mean that all the choices are going to be wise, but we are allowing people to make choices. And let me say this: the medical concern is not going to go away until we have clearly a sign that the rate of infection is precipitously going down and that mortality is following that curve. So that's one side. On the other side of this equation lies the, again, livelihood of people. And, we're seeing businesses going down, which again creates a financial hole in itself, because it's affecting not just the person who may own the business, but everyone who's working there, and maybe actually other sources of whatever it is, whether it's parts or whatever that business requires, even food, right? So I think that on one hand, the medical concern is one where it is, I'm going to say definitively, is not going to go away until this infection goes away. On the other hand, people are willing to risk the potential infection by moving into a much more open economy. This occurs in almost every epidemic situation or pandemic situation that is prolonged. I think that most people around us, you, myself, and others in our family, would love for us to fast forward this year and get it over with, because it is really putting a significant psychological as well as economic and social constraints on all of us. So there's no one side wins, the other side loses. It's going to be a trial and error situation. Now, the rationale behind opening is one of economic pressure, but it has to be somewhat tailored to be able to mitigate a precipitous rise in infection if that opening causes the virus to again resurge. And that's something which requires some planning amongst, again, political leadership.
All right, so I have one more question about kind of looking around the world before we close out. But to follow up on that, specifically when it comes to regaining a sense of normalcy by eating indoors, we talked a little bit about this the first time that it looked like we would be heading towards indoor dining, but here in Philly and Jersey, it didn't hit like it did in southern parts of the country from Texas to Florida. So now that we have that back, and this is the first time since the first initial shutdown, the protocol that would be indoors, are we talking about how much trust we really have with these facilities versus protocol that would be the norm, no matter if you're inside a restaurant or if you're going over to a family or friend's house and you would partake the same way? Are we trusting that just by sitting down 6 feet away from another table, that's enough? Is there a need for masks? Is there still a stringent need to adhere to sanitation where, you're constantly washing or sanitizing your hands between courses? Where is that balance to be able to go back to a restaurant but also stay safe?
So again, safety in public areas is clearly a nuisance at this point. If you're going to go and dine in a place, yes, I think that uh, looking at this from a point of view of social distancing is your first rule. Second is that the people who work in the establishment must again wear protective equipment, both for themselves as well as for their patrons. The hand washing, I wouldn't say that you need to wash it in between each course, but definitely the staff needs to be well aware of the fact that they need to keep hand hygiene as well as being masked because they are moving from one table to the other. So again, it behooves them to manage that. Um, there is a higher risk. There's no question there's a higher risk of dining indoors as compared to dining outdoors. But you try to minimize that risk by, again, applying all of the rules that we have up to now. The distancing, the mask, as well as the hand hygiene. And the other question, of course, is the availability of testing. And the question, of course, is we don't have a vaccine right now. And does the test offer a second line protection? Meaning that if the healthcare, sorry, the workers in an establishment that delivers food indoor, they have periodic testing, and the periodic testing in terms of frequency needs to be established, but whether it's one day or once a week or whatever it is, has to be there because these individuals leave the establishment and go home at some point, and we really don't know what the level of activity is. So testing becomes protective in many ways while we don't have a vaccine. As far as what the patrons can do, again, they need to be cognizant of social distancing and, again, take all the precautions that they can. On gathering at friends and family, right? The best is try not to unless you want to, and because of a celebration or whatever, and then limit the number of individual. And yes, uh, follow the same rules for protection. Once you're together, wearing a mask is the one that's recommended. Now, do you have to wear a mask all the time? Preferably, yes, but if you're going to be drinking and eating, you're going to have to take it off. So again, these are risk mitigations. They're not absolute 100%, but the more you do to protect yourself and others in whether it's a social situation or a family gathering or or eating outside, the less you are at risk.
So, one issue that has added a lot of confusion in, I'm sure, the medical community and everybody outside of it is what's happening with blood plasma, how politicized it's gotten, and also trying to figure out what's real and what's just being hyped up by unproven tests and data. Can you just do your best to untie the knot of misinformation and get to the center of information regarding blood plasma and its impact and effect on what we're dealing with COVID?
Well, first, I wish I could do that because I could tell you that there is an enormous amount of confusion. So let me just back up for a minute and explain what's happening here. What you have basically is plasma that is taken from individuals who have been infected, have survived the infection, and now we assume they have antibodies against the SARS-CoV-2. In fact, what happens is that when we start looking at this population of individuals who are donating plasma, there's an enormous variability of antibodies in their plasma. So that's the first thing. Two, we really don't know how much antibody exposure, meaning how much antibody is actually needed to fight the SARS-CoV-2 in an effective way. So you're dealing now with the fact that, yes, the plasmas, I mean, this is all based on all data with horse serum, Back in the days when they used horse serum to treat toxic infections. So again, you take this plasma, you have no idea what the titers of antibodies are, and you also don't know the quality of the antibodies. Uh, there are different types of antibodies. There are some that are neutralizing, is what you want, because they actually attack the virus, and there are other antibodies which don't neutralize, which don't do anything. So you could see how, as we build the case on this, how complex this issue is. First is the variability of antibodies, the type of antibodies, and we don't know what is the exact dose of antibodies that's going to do that. What's happened is that when we had the H1, when we had the SARS, when we had the MERS, all of these infections, people used what's called convalescent plasma, which is the plasma from people who had been infected and now have gotten over the disease, with varying results. The results were not that strong. Had they been very strong, this would be a first-line therapy for patients who are positive and have clinical infection, whether it's severe or not, with convalescent plasma. The data we have so far is very confusing because a lot of that is not what's called randomized controlled trials, meaning that people feel strongly that it's going to help you. They give it to you. If you survive, they're going to say it's because of the plasma. If you don't survive, they say it's because you were too sick. So, and we missed the opportunity to give the plasma. When we give the plasma is another conundrum because we don't know when. There has been one trial from the Netherlands, which actually was well conducted. It wasn't a large trial. It was under 90 patients. But it was conducted well, and that showed absolutely no difference between those who received plasma and those who didn't. In the United States, the FDA, until a while ago, allowed you to apply for this plasma under what's called the Emergency Use Authorization, EUA. And that meant that you can give one person the plasma under those circumstances. That is not a trial. And again, if you believe the plasma does something and the patient survives, you're going to say it to the plasma. If you believe it's a plasma and the patient doesn't survive, you're going to say they were too sick. So now the problem is that the FDA said we're going to stop this EUA, meaning we're not going to release any more convalescent plasma. And the reason they said that is because they wanted to do randomized controlled trials. And as long as you have an EUA, you cannot recruit patients to the randomized controlled trials because your family is going to ask to get the plasma for you. And if I can get it under EUA, I'm not going to enroll you in the trial. So what is happening is that they lost control over doing these trials. And unfortunately, what happened was the FDA did withdraw the EUA, but then politically it was made, and using, by the way, erroneous data, both publicly as well as internally, to show that plasma has actually a beneficial effect based upon, again, pretty erroneous assumption. And as you know, people retracted their comments afterwards from the health department. We now have a problem because the EUA is back, whether politically or not doesn't matter. It's just back, and now we're going to have trouble getting randomized controlled trial participation. So we will never know if this continues whether plasma helps. Now the problem with this is that this also interferes with blood donation, because if we do need blood and people go to donate and they're taking up a seat for plasma when they should be really giving blood, that's a whole other issue that we have to deal with. So here's a problem that could be easily solved, but because of both, I think, and I have to say, I think media is only showing you people who survived, who got plasma. They're not showing you anyone who got plasma didn't survive. again, a very big bias, and also the whole issue, the political issue around the plasma. Uh, we just basically are not going to get the answer, which is very unfortunate.